Thank you very much. I'm very pleased to have this opportunity to talk to you this afternoon, be invited to offer some challenge, be a bit controversial. So here goes. Bruce has introduced me, Helen Crisp from the Health Foundation. And what I'm going to say is based upon 17 years' experience, latterly at the Health Foundation, but prior to that as a consultant and working on accreditation programs, at working with teams on quality improvement. To the extent to which any of this is evidence-based and has some coherence, I must give credit to Mary Dixon-Woods, a professor at the University of Leicester in England, who is working with the Health Foundation on a number of research projects into what works to improve healthcare services. And so this is very much based on some of her work. And in particular, she and her team recently carried out a review of 16 evaluations, externally conducted evaluations of Health Foundation programs, which have been carried out over the last 8 years. So just to give you the basis of what I'm going to say. So, does quality improvement need to improve? And my contention is that yes, it does. What we hear at conferences like this are successes of different projects, but we have to balance that against the fact that we appear to have little impact on reducing levels of harm. We often hear quoted the studies that show that on average 10% of hospital inpatients suffer some form of adverse event whilst they're in hospital. And some of those reports are quite old now, so you might be thinking, well, you know, that was from 10 years ago. We've put a lot of effort into programs since then. Surely it's changed. Well, I have to tell you that just in the last year, we commissioned an evidence review on studies into levels of harm at the Health Foundation, carried out for us by an organisation called the Evidence Centre. And that report showed that the studies continue, they continue to reveal the same sort of levels of harm, and some of them, admittedly using broader criteria, are showing much higher levels of harm than we previously realised. So yes, so it's disappointing that, what are we now, 20 years on at least, in quality improvement, in having a patient safety movement. But we seem to have made little impact. Healthcare has a safety record which just does not stack up against other industries. And I'm not just talking about the airline industry. I'm sure at this conference and at others you will have seen comparisons with safety in airlines, and that is very, very high. But again, we have commissioned some research to look at how safety is managed in other safety-critical industries and sectors. We don't have the findings from that ready to publish yet, but the early evidence shows that healthcare is an outlier compared to sectors such as road transportation and the building industry. So we have some way to go. And what are some of the barriers to why we don't seem to be getting the success that we would like to see, that we hope for, and that we are all, particularly at a conference like this, 100% committed to? Well, there are several problems around the design and implementation of our quality improvement efforts. One of the issues is problem. What problem? Not a problem round here. People working at the front line don't necessarily recognise the issues that people from quality improvement are telling them that they need to improve on. Quite often they're asking what's the evidence for this, for saying this is a problem. And in some sectors we are, for some services, we're inappropriately trying to put in place quality improvement interventions, because if it isn't recognised as a priority, the staff in that service will just feel, well, you know, why are we bothering with this? There are many other more important things that have a higher priority for me. So we need to be much more conscious about matching our solutions to problems that are seen as real problems and are seen as local problems where we're trying to do the work. Because that's the only way that we'll really engage staff beyond the enthusiasts. And when we're not working with the enthusiasts, I'm sure you've all been in front of meetings where you were very aware that you weren't talking to the enthusiasts, and the question asked about, what's the evidence for this intervention? Can you show me the proof of where this has worked? And too often our evidence is patchy at best, where we might say, well, we've got some evidence, we've got some excellent reports of this written up. Too often they are self-reported, and I'm not suggesting that people are dishonest, but there is a tendency towards being positive about work that people have been involved in, and where they want to show that they achieved results on the basis of their funding, that they are, a good team to invest for further projects, and so on and so forth. So there does tend to be a bias towards success in some of the reporting. Again, the question about the evidence, often based on rather poor, not as rigorous data as we would like. And again, this is because many of the data collecting systems in our healthcare organisations were not designed for the purpose that we're now trying to gain data from the Quality Improvement Initiative. So it perhaps doesn't quite mix. When you look at it in real detail, is this data that we're presenting really showing the solution, that the solution works, or that it was related to that improvement intervention? And sometimes it becomes a very burdensome aspect of quality improvement. Again, frontline staff are asked to do a lot of additional data collection because we're trying to build this evidence base, but we need to be aware of how much work that is and ensure that we've got the right people doing that, and perhaps we can put some clerical input into that programme to collect the data and not expect frontline clinical teams to be doing this, because again it's a real turn-off for people to feel that they're doing work that isn't their sort of work, and they can't really see the point of it. Another problem with our planning and design is that we're enthusiasts. We have a can-do attitude. We really believe that these things are going to work, and we set ourselves stretch goals. Marvellous. Except that sometimes this is unrealistic. And we've had a very salutary experience in the Health Foundation of this, our Safer Patients initiative, which we funded across 24 hospitals in the UK to some tried and tested quality improvement approaches, various quality improvement bundles made up that initiative. But in our enthusiasm and belief in the programme, we set the goal of reducing adverse events by 30%. The programme finished a couple of years ago. We've had a full external evaluation, and the evaluation showed that that programme did not reduce adverse events by 30% or anything like 30%. Now, that is not to say that the programme was a failure. A lot of good results were achieved, but the goal that we had set and were publicly striving towards, with hindsight, it simply wasn't realistic. In the time scale, we just weren't likely to achieve that, and the dosage that this programme managed, we just weren't going to achieve that 30% reduction. And I think we were also possibly guilty of the other great sin in this field, which is underestimating the resources required for programmes. Again, quite often we're trying to get other people on board, we want to make it look appealing, and so again it can be quite tempting to somewhat underestimate, really how much time and effort is this going to take. Another area that I would like to get us to just think a little bit about: projects and piloting. Project status, it's a double-edged sword. Projects often are able to secure additional funding, which is great, gets the thing off the ground. often gains attention, particularly if you're selected to be involved in a project. Your unit, your hospital is selected. That's great. We can give a good news story to the media. Often very useful in getting top management engagement, which we know is very important. So that's the good side about projects. But the downside is that projects, by their nature, are short-term. They tend to be seen as outside of the mainstream of work. And so too often, improvement interventions that are implemented through a project, they fail to really gain traction, get embedded, and become the way we do things around here. And in terms of working on projects, we often look for particular organisations to pilot them. And we would like those to be top-performing departments or hospitals. Yes, that's who we'll have to pilot our organisation. But then we're surprised that the average performers fail to reproduce the same results. So I think we need to rethink how we approach some of these. I think we will carry on with projects, but we need to be mindful of the potential shortcomings. I think there is a real challenge with who we choose to pilot these interventions. And I think there is a real case to be made for ensuring that your intervention is such that it can be piloted by the average. It doesn't require excellent facilities, a top-performing team, etc. So we have to be mindful of these frustrations because there's only so much capacity in our organisations for improvement interventions. Every new project takes up staff time, takes up organisational resources, and it's just the capacity to be able to engage with these things. So we need to make sure that we're engaging with the ones that are really right for our organisation. Because there are some signs of growing cynicism, or enduring cynicism, maybe. And I want to here touch upon the nature of healthcare staff. Very often we hear that all healthcare staff are 100% dedicated to doing a good job. I'm not sure that we can really say that, or if they are interested. Of course, most people are interested in doing a good job. 99% of people are interested in doing a good job. So that isn't particular to healthcare staff. So again, we shouldn't act as if we're working with a different group of people with different sorts of motivations and limitations to the rest of the population. Healthcare staff are human. They need to see what's in it for them. They need to not be overburdened with projects, and they need to be supported to change the way they work. Because otherwise, resistors know that they can probably ignore the latest quality initiative because they just have to wait it out and it might go away. Great story, again from Mary Dixon Woods. She was doing some on-site work at a hospital, talked about being involved in their quality initiative programme, and there was a sort of wry smile. And they said, oh, we've got something to show you, the cupboard of lost projects. And there, literally, as she tells me, in a cupboard on the ward was every information pack, CDs, record-keeping folder, etc., for all the quality improvement initiatives that this particular department had been involved in over the years, and few of them had really sustained. And I think there is a real worry about the sustainability of some of this work. Our evaluations, in common with many where there is an external evaluation, have been for the lifetime of the funded project. But if we went back in 3 years, in 5 years, would we see traces of that work, or would we experience the evaporation effect? That once the drive has moved on, the funding has finished, in actual fact, the gains somewhat recede. We're looking for success in our projects, but does this mean that we're taking enough risks? Now, I know a lot of healthcare organisations can't take risks, but if you're an external agency or an independent funder like the Health Foundation, we must be prepared to take risks so that we can be innovative enough. And in that case, we have to be aware that some of our interventions will not succeed. They won't deliver the results that we're hoping for. And we need to approach that with open eyes and stop being success junkies. I know nobody wants to be the interesting failure from which so much can be learned. But where we find that something doesn't work, it's really important that there is honest reporting of that. And I've been really interested to see more open and honest reporting, very much sort of warts and all studies that have been coming out. And I think that's a very positive movement and a sign of maturity in this field. The other problem we have are the pockets of excellence and getting spread and take-up where something has been proven to be successful. We just seem to get pockets of excellence in healthcare. Now, sure enough, some of those pockets are now pretty big. You know, we have got really excellent organizations and sort of multi-unit, multi-hospital organizations, particularly in the States, that are showing quality of care and excellence. But it's so rare that we really get something that really spreads like a virus across the healthcare system. And spread seems to be hampered by a couple of factors. One is underestimating the importance of local context, where something has worked, what was the particular situation there, and therefore understanding why it worked. And I think, again, we're seeing some interesting study into that. So there are some cultures that support improvement and others that inhibit improvement, or that you need to approach the improvement in a different way to make it work in a different organisation. Too often, improvement reports are not well written up. You hear about something, you see a poster or a presentation at a conference like this, and you think, oh yes, I really want to know, what did they do? And then you get the report and you're reading it, and they talk about the results and the problems that they tackled and the results they got. But sometimes you just cannot grasp, what did they actually do? So we need to get better at really explaining the methodology and being clear about what are the irreducible elements. What is it that is needed in that program for the veracity of reproduction? And this is a tricky balance, because we also learn from the literature about the need to adapt, as I was saying, take account of local context and adapt the improvement intervention. So there's a balance there, adaptation towards what are the really core elements that if you start changing those, you won't have the program as it was supposed to deliver. So what's my conclusion? The effort is commendable, but our overall report card for the last 20 years of improvement in healthcare, I think it really needs to be, shows potential, but needs to improve. We have to be honest that this is hard stuff, and we need to be in it for the long haul.